President, ladies and gentlemen. This subject has already been introduced this afternoon, but I'd like to just remind you that liver resection potentially cures and treatment of patients with primary hepatocellular carcinoma or advanced metastatic disease. And unfortunately, hypersurgery is a major operation which does incur significant morbidity and mortality. Quite a lot of this is attributed to liver failure. But there is no doubt that some of this is due to the small volume of liver remnant that is left behind. During the process of the liver resection, that small remnant is damaged. Part of that process is due to ischemic reperfusion injury, which occurs when the Pringle maneuver, which is already mentioned earlier today, is applied, and the clamp is applied across the portal triad, rendering the residual liver ischemic, and there's an attendant reperfusion injury once this clamp is removed. Whilst this applies in elective liver surgery, there's a more severe injury that occurs in liver transplantation, which is exacerbated by events which occur within the donor, and also a prolonged period of cold ischemia and cold preservation. There's currently no treatment for this. However, the area of preconditioning as pre-treatments which you can give to the liver to enable it to survive this injury is an expanding field. Heme Arginate is one candidate enzyme which we could use to improve outcomes in liver surgery. This enzyme degrades heme, generating end products, biliverdin, carbon dioxide, and free iron, and these products have cytoprotective properties through a variety of mechanisms. It's previously been shown in a wealth of data this does protect from hepatic ischemic reperfusion injury. However, despite over a decade of research in this area, there is yet no clinically relevant drug which we can give to patients. And in this study shown in the bottom of the screen, they used cobalt-coated fire, which is toxic, or adenoviral induction of Heme Arginate, neither of which would see their way into clinical trials. We've chosen Heme Arginates as a drug which has readily been available for the treatment of porphyria, and been used clinically over the last 25 years as an established safety profile. Heme is this prototypical HO1 inducer, as you'd expect. It's the subject of the enzyme and it readily induces it, and it has potential human clinical trials to induce HO1. We hypothesized that Heme Arginate would be capable of inducing hepatic HO1, and that this treatment would reduce hepatic ischemic reperfusion injury. We studied systemic HO1 induction using traditional enzyme assays, Western blot, and immunostaining, and we established the efficacy of HO1 induction protecting from ischemic reperfusion injury within a model of partial hepatic ischemic reperfusion, where the left lobe of the liver is clamped for 40 minutes. We had phenotyped bone marrow-derived macrophages, which we appreciated by our drug, and I'll go on to more about that during the course of the presentation. And we examined the functional effects of the phenotype change in these macrophages within a co-culture model, co-culturing macrophages with tissue slices. Our initial results confirmed that Heme Arginate readily induces HO1 within all solid organs, but here demonstrated within the liver, increasing functional activity, and also the protein within the liver demonstrated by Western blot. Immunohistochemically, this was localized within the Kupffer cells, as you can see by the characteristic distribution within the liver, and also within the perifollicular area of the spleen, where the macrophages within the spleen are resident. This was confirmed by dual immunofluorescence, using F480 here in red as a macrophage marker, and H1 stained in green. It then shows co-localization of H1 overexpression within the Kupffer cells. Our second hypothesis was to see whether Heme Arginate would protect from ischemic reperfusion injury, and it did in animals which were treated with 30 milligrams per kilogram of Heme Arginate 24 hours prior to injury. There was a significant reduction in their ALT release, and also this was confirmed on a histological injury score as marked by 2 blinded observers. We examined the inflammatory cell influx into these damaged organs and found that Heme Arginate also reduced the influx of neutrophils. It did, however, have no effect on the number of macrophages present within the organ. However, due to the fact that the HO1 was upregulated in tissue macrophages, we were interested in the effect Heme Arginate had on macrophage function. And we showed that Heme Arginate induced an anti-inflammatory phenotype within these cells as characterized by low levels of nitric oxide production and high levels of IL-1. There was no change in TNF-alpha production. To address whether this was functionally relevant, we co-cultured murine bone marrow-derived macrophages with precision-cut tissue slices of murine liver, which had been subjected to 2 hours of warm ischemia. These were then reperfused in vitro for 24 hours, and ALT and LDH released within the culture circulating was tested. And this shows that Heme Arginate treatment of bone marrow-derived macrophages afforded protection from the liver. This is obviously a murine tissue, and just to confirm whether that worked in human, we used human monocyte-derived macrophages and co-cultured that with tissue which we obtained from patients undergoing elective liver surgery, who've been given fully informed consent, and these slices were subjected to 2 hours of warm ischemia and then again reperfused for 24 hours And in the presence of monocyte-derived macrophages which have been pre-treated with Heme Arginate, this was able to significantly ameliorate the degree of damage in these slices, as measured by caspase activity and LDH release. To confirm that these macrophages do have an anti-inflammatory phenotype, we then administered these by adoption transfer. We performed our ischemia reperfusion injury within the murine model, and immediately post-clamping we did 2 million polymer-derived macrophages intravenously. These macrophages have been pre-treated ex vivo with Heme Arginate. And we were able to show here in the last 2 bars that macrophages have been pre-treated with Heme Arginate and a protective effect compared with untreated macrophages. Therefore, to conclude, Mr. President, ladies and gentlemen, we've shown that Heme Arginate does induce HER1 in vivo. It also capable for protecting from hepatic ischemia reperfusion injury, and it does this through inducing an anti-inflammatory phenotype of macrophages. We think this is a potential candidate that can be used clinically and can be used either systemically or using cell-based therapies. Right,
very slick presentation, very nice. I think one of the problems everybody in the room has who aren't familiar with the injury is the correlation of all of these early changes that are biochemical or cellular in the mass, are indicative of clinical damage. And I think that's something that, if you'd like to just comment on that, it'd help a lot of us, I think, in the room would have done several of these papers.
Well, this is a standard model which actually is very similar to does occur in insurance suggested to below. As has been discussed already, ALT and AST by themselves are not clinically relevant. Clinically relevant endpoints would include infection, length in ITU or HDU, time to discharge. None of those can be addressed within the murine model following regulations. We're limited to 24-hour recovery period for that, so we can't actually address that within this model. We do want to pursue that in a liver transplant model, which we're essentially
if you're down, blame so you're going to randomised controlled trial and you try your drug. What is the endpoint you're going to choose in your phase 3 trial? What is the primary endpoint you're powering?
Well, the endpoint for the phase 1-2 trial is biochemical to see if we can induce HER1. And then we're going to use length of stay in hospital and infection rates. So we haven't established we've published it previously where CT, bilirubin, and encapsulopathy and Schindler score published in 2005, which we think we could use as our main endpoint. However, that depends on the results of phase 1-2 trial, and only by doing that will we be able to cover our phase 2 study.
Talk about the lack of drugs. Is the crystal structure of Heme Arginate known?
Yes, it's crystal iron 9, which is a heme ring with iron in the middle of it.
So presumably you've spoken to your chemistry departments where you can search in these massive databases to find whether there's peptide sequences which you could potentially design new drugs that might be more appropriate than your Heme Arginate.
That's true. From a pragmatic point of view, this is already available.
It is safe. That's an important factor, isn't it? Mr. Labour.
Presentation. The own unit method has shown that the median hospital stay for liver resection can be used in 5 to 6 days. Now you can use reduction in hospital stay as a primary endpoint. How much further you can reduce hospital stay by?
Well, yes, not all of our patients are in ERAS, but yes, it's going to be difficult. I would prefer to have a functional endpoint looking at liver function. We are in a clinical trial looking at ICG clearance as well as our Schindler score. But yet, it remains to be seen whether that would be useful for our phase 3 study.
Were you suggesting dedicated hepatic transplantation? Any other questions? Fine. Thank you very much.